Guys, please just log in with your name, please. Please, guys, not FS or not like iPhone. Just please. So in musculoskeletal system, what we'll do, just before examining child, we have few, if the opening statement just like do the PGAS examination, then the opening statement is very much clear. But sometimes the opening statement may change, just like this child having difficulty in walking, please examine. This child having difficulty in writing, sometimes please examine him. So these are the opening statement. After that, if the opening statement is clear enough, okay, if the opening statement is clear enough, I will request everyone, please just log in with your name, please, so that will be easier. Okay, this is a small group, please. Okay, so yes, so a screening question. So screening question, as you can see, there are 3 screening questions that can be done before these figures. So first screening question is, do you have any pain or stiffness anywhere in your body or joints? This is the first screening question. So according to that, we'll just proceed. If the child is directly saying that, yeah, I have pain in this joint or maybe, then that will be focused examination. That is different. But if the child says no pain, then next question will be okay. So second question mostly is indicating whether any kind of abnormality is there in the upper limb or not. The question is, do you have any difficulty in just dressing or undressing? So this typical question is for movement of the spine as well as upper limb. The second question. The third question is, do you have any problem in the upgoing, going up and coming down from the downstairs? So this question is basically assessing the lower limb function, and if there is pain or joint restriction of movement, just like this. So these 3 questions is mandatory before the examination. After that, so I have already entered this station, and after taking permission, these 3 questions, and after that we'll just observe the child. This is general observation, part of general observation. Okay, that will be included 4DMS. In every station we'll follow like this, 4DMS. Okay. Guys, this is one more time I'm requesting, please just log in with your name, please. Okay.
Chat is turned off.
Yeah, I think you have done, but okay.
The chat is turned off from your side.
Chat, yeah, I have kept off this chat. Sometimes problem for me to concentrate.
Okay, no problem.
Okay.
Please.
Okay. So this is the first part of examination. This is common for every station. After this is called first look or just screening. So 4DMS, whether any distress, dysmorphism, growth parameter, that is dimension, including the head circumference, and the devices. Here in this station also some devices can be there, just like splint or some orthotics, just like neurostation. Okay, so we need to identify all this devices. After that, the dimension, that is both parameters, and is all this 4D. Okay, and after that, mentality, definitely mentality. So here mentality most likely will be normal, but still if this is a syndromic child, there is some degree chances are there that the mentality or the IQ level or the heart function will be little lower side, maybe possible. That's why we need to talk to the child at the same time. So after just talking with the child, we can have an idea this child have normal mentality or just low IQ. Then in the standing position as well, if the child is standing, then we can also look for any scoliosis is there or not, any kind of deformity with posture. That is the key of this station to identify actually the abnormality. And after that, few cases there may be rashes, Okay, so we need to identify, and some rashes including the psoriatic rash. So psoriatic arthritis is also one of the exam case. So rash is not only just for like one case. Okay, there may be different type of rashes, so we need to identify the rash, and after that some neurocutaneous marker as well, if there is any black or white spot, something like that. So all these skin manifestation, including the posture and joint and the deformity, actually we need to identify. After that, look at the position of the knee, whether that is important. If in knee as well as elbow, any every joint, if there is any kind of deformity, we need to identify and respect. And after that, look and into the limb length. So this is the most important area in MSK as well as the neuro. So this vital piece of information should not miss, because if we miss the limb length, this is called LLD. If we miss this LLD, definitely will be downgraded. Okay, definitely they will be downgraded us. Okay, so that's why this is must. So this LLD is very important. So now during the observation, we need to check from the front, from the back, as well as from the side. So as we can see, is that again, the same description has been written here. The bulk, basically, if this is a chronic inflammatory condition, just like joint involvement, there may be some degree of atrophy, okay, some deformity, and some inflammatory changes over the joint involved, okay, especially the asymmetry sometimes, and yes, all these things from the front and same from the back. That is, whenever we are inspecting from the back, the alignment of the spine is also important, and the gluteal muscle asymmetry, all this muscle thing and alignment we need to see. After that, from the side also. So side also, this is one of the important finding here, as you can see in this slide, that just a minute. See this lumbar curvature. That is some cases we can get lumbar lordosis. Okay, so lumbar, that is lumbar and thoracic and all this curvature usually best seen from the side view. So that's why side view is important. Now this is total part of inspection and inspectory finding. Now what we'll do, the next step is checking the gait. So here detail, okay, some background noise is coming, I think. Okay, Dr. Mohinder, can you please mute yourself, please? Okay, thank you. So the gait is the next step. After observation, we'll start with the gait. Okay, so gait, no detail. I mean, there are 7 types of gait. So all the gaits are not necessary. Just walking on the heel. After that, tiptoe and normal gait. Normal. I mean, yeah. First of all, normal gait. Ask the child to walk normally. After that, heel, then tiptoe. These 3 steps are just sufficient for this examination of MSK. And after that, we'll just during when the child is standing, we'll observe few more things, just like curvature of the the foot. Some cases there may be high arched, and there's some cases there may be just a minute, guys. Okay, sorry. So high arched may be present, and sometimes we need to check the deformity, if any kind of deformity is there, or sometimes some scar may be also present. So all this finding may be present in the lower limb. So including this gait, we'll check. Now the second thing is during this is the standing position. So we are checking the gait after general observation. After that, we'll check the Gawa sign, because I will ask the child to sit down and just get up. So what happens in this time, if the case is sometimes difficult to identify, then some proximal muscle weakness or muscular kind of cases may be there. So that will be prominent during the checking of Gauss. This is one of the important clinical examination that should include in neuro as well as MSK. So if any kind of pain, so that will be prominent, number 1. If any kind of proximal muscle weakness, then definitely the Gauss sign will be positive. So that's why Gauss sign, it is a must. So that will be, beneficial during this MSK. Okay, now if there is scoliosis, we'll ask the child to bend forward to see whether this is positional or some pathological. This is up to this, whatever we have discussed till now, this is just in the standing position. So we have completed our examination during the standing position, so that we will never ask, afterward the child will stand up and will say something. So this completes our examination in standing position. Now in the sitting position, we'll start with the Piga's examination. Okay, the steps are there. I will just show you the picture. Before that, we'll discuss ask the child to stretch out both the hands. Number one step, so we can see what are the things. There is deformity. Some of the exam cases there was absent finger or thumb, absent thumb, or some permanent contracture is there, and sometimes there may be prominent. There is thenar and hypothenar eminence. There may be atrophy as well, if this is nerve injury case. So all this finding may be there, and sometimes in the hand there may be proximal interphalangeal or distal interphalangeal muscles, swelling or some changes of some deformity may be there. So all this finding will be prominent when the child will outstretch the hand. Number one step. The second step, we'll just ask the child to make a fist and make a star. So whenever the child is making the fist, at that time, if there is any joint involvement, like small joint involvement, the child will be unable to make the fist. Okay, so that at that time we'll be able to see that there is some degree of weakness during making the fist. So at the side, we will just also see the muscle strength. Maybe we'll just palpate to see whether the weakness of muscle is there or not. And making a star also, that in that time maybe some of the joints are not opening the stretched hand with making the star. So that is an important finding if there is like hand involvement, like JIA, polyarticular. Okay, so this is the second step. Third step is just pinch your finger or touch your finger with the index finger and thumb to make a circle. So make a circle. Just the comment is make a circle, so that we can identify the coordination as well as the function. And if there is any bony deformity or any muscle weakness or anything abnormal, that the child will not be able to make the circle. So this is the third step, and this is the fourth step, and the fifth step we need to squeeze the metacarpopharyngeal tenderness. Okay, so these sometimes what sometimes we used to forget this step. Okay, so that's why this is important. Squeezing the metacarpal, not so much of forcefully. That will be just light squeezing, and after that we'll put the hand. This is called that prayer sign. So I will ask the child to keep both up hands together to make a prayer sign, and we'll ask the child to flex the wrist joint in a full. So that will be the prayer sign, and the opposite moment is the inverted prayer sign. That is enough for Piga's examination. If some joint examination in detail, a few more movement is there, but we are not going into detail right now. So this is just Piga's. So this part is up to this part. This is the hand. And now reaching. Now this is cervical part of examination. So can you touch the sky? So the child will be touching the sky with both the hand keeping upward, and at the same time we can ask the child, can you look upward towards the ceiling? That is extension of the neck. And after that we'll just put our hand. We'll just ask the child, can you put both the hand behind your neck? Okay, so that is abduction of the soleus joint. After that, the external rotation of the soleus joint. So these are the steps. We'll see the picture, that will be more clear rather than describing in this way. Okay, after that we'll just ask the child to open your mouth and put 3 fingers. So we'll check the temporomandibular joint, and now we'll ask the child to lie down, and here we'll just see the knee joint, including any effusion is there or not, like patellar tap, and flexion extension of the knee joint and hip joint, that is flexion extension as well as internal rotation and external rotation. That's complete our PGALs. So if we see the pictures that is given here in a haphazard way, but it's always better to see in a structured way. So first step, if you see, the first step is gait. So after entering the room, not the gate. So first thing is general observation, and after that we will just ask the child to walk. Okay, the general observation part from three directions, just like in front, inside, from the side as well as from the back. And after that, that is gait. So gait, normal walking. After that, on heel and on toe. That is enough for PGAS examination. Okay, then after this walking, we will just here few more steps. I just said during the standing position, we'll check the Gawa sign as well as we'll check if there is any kind of scoliosis. We'll also ask the child to bend forward. So gait along with these two steps will be there. Now arms compression. Can you stretch both the hand, outstretched hand, that finger, small fingers and all this joint will be examined. So this is the arms. So there's step C, and the child is making the fist in the next step, and after that just making a circle. Then we just here not only making the circle, he is touching all the fingers with the thumb, and after that squeeze the metatarsophalangeal joint. After that, make a prayer sign, inverted prayer sign, then look upward. I mean, just try to touch the ceiling, and then extend the neck. Just look at the ceiling, and then just keep behind the back. That is both the hands. This is arm part complete. Now legs, as you can see in the picture, the legs, the steps is first we need to see whether any kind of pain is there or not, and squeeze and tap. Okay, then in the knee joint, flexion extension, and the hip joint is flexion extension. After that, internal rotation and external rotation. Legs complete. Then spine. Okay, spine is given here at the last, so that can be done with arms only. Okay, so spine, what are the steps? Then first of all, okay, I think spine little bit of here we have done. Yeah, this I and J, that is also involving the spine, where the child is looking at the extension of the neck, and at the same time there is another step. Can you touch the finger? We are with the soldier. So lateral flexion of the cervical spine can be done here. And after that, this is the third. Can you open your mouth so that the temporomandibular joint can be checked? And here is the step that can you touch both the ears one by one with your soldier. So that will be complete or PGAS examination. So that will come with more of practice. Okay, we'll practice one by one. So this is PGAS. So this is the same thing. I have made a slide. So now specific joint examination. So if the task is this child is having some difficulty in walking, then the examiner will be indicating that the lower limb examination is the lower limb examination involving not only any one joint, that is joint involved. Just if this elbow joint is involved, we need to examine the shoulder as well as the wrist joint and hand, and check the spine angle. This is must, because not only one joint, there may be a few more joints involved at the same time. Okay, so look, feel, move, and look, feel, move at the same time. There will be another function, assessment of function. So these are the steps. So that is sometimes very difficult to remember. In hands, what are the joint movement? The number one hand there are 4 movement. So again, make a fist, make a star, and after that circle and touch each finger. Do not forget metatarsophalangeal joint involvement checking. Then wrist again. If there is a swelling, then we can ask the child individual joint involvement. We can ask the child that can you make a prayer sign and then inverted prayer sign. After that, lateral ulnar deviation and Ulnar deviation, radial deviation, over. So it's 4 and 4. After that, elbow, again it's 4. What are the movement? Flexion, extension, supination, pronation, over. Then in the soleus joint, there are a few more movements. That is total 6 movements. Okay, in the soleus joint. So flexion, extension, abduction, adduction, external rotation, internal rotation. These are the 6 movements in the soleus. So I'm not going into the detail of all this, so you can watch the video as well. That will be clear. So at the same time, the gait and spine examination. Okay. Now, if the task is do the like spine examination, okay, then spine examination, what happens usually, we sometimes miss that there's not only the thoracic spine, there is the lumbosacral as well as cervical spine. We need to examine at the same time. We need to check the gait as well, because gait is coming from the spinal, spine. So again, just we examine in our PGALS examination, the cervical spine involving, that is look up at the ceiling, that is extension of the neck, cervical spine, or then flexion, and lateral flexion, then lateral flexion, and then lateral rotation. These are total 6 movement is there. Okay, so we need to remember the actually this what are the number of movements. So sometimes that will be easier to remember. Otherwise, some moment that's possible in the exam you will forget. In the thoracic, as you can see, there is also 4 movement: flexion, extension, lateral flexion, and lateral rotation. Thoracolumbar again 6. Thoracolumbar is also forward flexion, that is extension, that lateral flexion, rotation, and finger extension. So these are the movement. If we see some video, that will be more clear. So this is basically specific joint examination. Now, if the task is please examine the lower limb of this child. So again, gait will be we'll begin with the gait. After that, the hip joint. There is 6 to 6 hip joint. So most common examination in our exam, that is hip examination. Lower limb examination. So that will involve the hip joint. There is 6 movement. Okay, flexion, extension, abduction, adduction, internal and external rotation. Okay, knee joint. There is another flexion, extension, and that is active as well as passive. So in every time we need to do the active movement first, after the passive. And ankle joint, there is also 6 movement. Okay, that is inversion, eversion, and lateral deviation, extension, flexion, and lateral deviation. That is the joint is little different. It is tibial talar dorsiflexion and plantar flexion, and subtalar inversion, eversion, and supination, pronation. These are the total 6 movement here. So now we'll just move for the practice. These are the movement in basic, so that will come automatically with more of practice. Okay. So this is our first case. That is sometimes most common exam case. We'll move into the practice now. Okay. So Danish, who is 14 years of age, kindly do the detailed joint examination as needed. So here, opening statement is just like do the PGALS first. Okay, I'm just changing the opening statement. Is do the PGALS. So PGALS is the most common opening statement in the MSK. So anyone who is already confirmed the seat can do the PGALS. just will follow the basic structure. After entering the room, I will just observe the child, introduce myself, and then wash my hand. At the same time, after that, I will take the permission from the parents as well as the examiner, and I will observe the child from the beginning and from the bed end. So any kind of dysmorphism is there or not for this. Okay, dysmorphism devices. Also. So in this way, we'll just continue just like our other.
Dr. Pranab, I'll try.
Sure. And after that, we will go for the discussion of the specific case. Okay. So take your time. Your preparation time
Doctor,
is yeah, please.
Can I have a quick question?
Yeah, please.
Like Gowers is important in every MSK?
Gowers is important in neuro as well as MSK because if the child is having proximal myopathy, okay, then there will be nothing in the joint. Sometimes in some of the exam cases that is very difficult to identify exact case. Okay, so maybe the child is presenting with rash and difficulty in walking or weakness. The child, yes, and
GDM.
the child will be replying just like during the screening question. The child will be replying, okay, I have some difficulty in just going upstairs. That is the only clue, and some rashes. And during our examination in the joint, there will be some weakness during the movement, and especially the proximal muscle weakness. So that is sometimes if this kind of cases is given that the time, this Gauss sign will help us.
No, I mean to say, like once actually suspecting, like this case actually requires a Gowers, then only do, otherwise not to do.
I can't get your point, basically.
Hello?
Yeah, can you repeat?
Like if we think the Gowers is required here, then only can do, otherwise in all cases not to do. No? Like in MSK.
So how you will understand that Gauss sign needed or not? So that is basically the individual approach. So what I feel, if we do Gowers in neuro as well as MSK, that will be beneficial. We should not miss any kind of clinical finding. That is my thinking basically. And if you feel that this is not exactly needed, and sometimes there may be this sign may be negative, so you can skip. But what I feel that this is better to do. So it hardly take few seconds maybe. Anyway. So Dr. Anusha.
Yeah, Dr. Pranab.
When you are ready, just let me know. Okay.
Yeah, I think we can start. Okay, so shall I start?
Wait, let me keep the time. Time is everything in this system. So we will not now and afterward we will not give any extra time. Okay, we'll just try to complete within 6 minutes. Otherwise,
Okay.
That will be difficult in the exam. So we'll be a little strict on the timing now and afterward. Okay.
Okay.
Okay, fine. So if you are ready,
Dr. Pranab, so I will keep telling everything. You will only tell positive findings, right?
wait,
so I will
guys,
not stop anywhere.
wait. Yeah, আমার মেয়েটা জালি থাকছে দাও।
வெளில போகணுன்னே கையில கையிட்டு வீட்டு எக்ஸாம் வேணும், சாப்பரோன் வேணும். அது கூட யாராவது இருக்காங்களா அப்படின்னு பாக்குறேன். அப்புறம் சைல்டை அடிக்குவேட்டா எக்ஸ்போஸ் பண்றேன். எக்ஸ்போஸ் பண்ணதுக்கு அப்புறமா சைல்டு கிட்ட நான் ஃபர்ஸ்ட் 3 கொஸ்டின்ஸ் கேட்கறேன். கொஸ்டின்ஸ் கேட்டு
Okay, sorry.
Yeah, okay.
Okay, so if you are ready, so your time starts now.
Okay. So I'm entering the room, washing my hands and introducing myself. Hi, Danish. I am Dr. Anusha, one of the pediatric doctors here. So, and I also greet the examiner and I take permission from him. Can I examine you today?
Yes, sure, Doctor. Sure.
Okay, that's nice. So Danish, I would like to ask you a few questions. And so, do you have any pain in any muscle or joint or in your back?
Okay, doctor. There is little pain in my both the hands only.
Okay, okay. Oh, I see that. Okay. And do you have any problem with your back? Any stiffness or pain?
No,
Okay. Can you dress up every day? Like, are you able to button your shirts?
no, that is also difficult, doctor, for
That's
me.
also difficult for you. Okay. How about walking up and down these stairs? Is that easy or difficult for you?
Which one? Sorry.
Walking up and down the stairs.
Oh, that is not a problem for me, doctor. That is not a problem. Yeah.
Oh, that's good to know. Okay. May I just ask you to expose, like, take your shirts off and also lift your pants a little above your knees. Will that be okay?
Yeah. Okay. I am wearing this half pant. You can. Yeah. See you.
Oh, that's nice. That's nice. Okay, Danish. I'm just looking around and seeing if the child is in, if there are any devices around. Also looking at the child if he is well grown for his age. And I would like to also plot him on the age appropriate growth charts. And I also see if he is in any distress and for dysmorphic features.
There is no discomfort feature, no distress, and growth is not appropriate according to the age. And yes, continue, please.
Okay. Now I'll assess his mentation when I'm talking to him during the procedure. And is he wearing any specs?
No.
Speech seems to be normal. Okay. Now I go ahead and I ask him, Danish, can you just please walk for me, front and back?
Yeah. He is walking.
He is walking. Okay. Is there any abnormality in walking in his
No.
gait?
No.
Next, I ask him to walk on his heels and followed by walking on his tiptoes. Is there any abnormality?
No.
Okay. Now I ask him to do the go sign. Ask him to sit in squatting position and rise up.
Yeah, there is no problem.
Okay, now I look at his back and check for any kyphoscoliosis or a lumbar curvature or any
Negative,
abnormal
negative,
cervical
negative.
curvature. Nothing is there. Okay, now I also ask him to bend down and touch his toes. Does he have any difficulty? Is the vertebral column normal?
Yeah, if there is no scoliosis, do not do this.
No, do it. Okay, okay. Now thank you, Danish. Can you please have a seat and can you copy me whatever I'm doing and do the same?
Please.
Okay, so can you please extend your hands out for me?
Yeah, he is extending as you can see. Yeah, extending as you can see, there is swelling in small joints all over the hands,
Okay,
as well
I
as
can
there
see.
is. You can see over the picture. Extension
So,
and extension of all the finger is not possible. There is flexion deformity.
okay, there's dissection. Also, I can see there's some hyperpigmentation over his knuckles. Also, there's some wrist effusion. I would like to feel for warmth and tenderness over the wrist and the other joints involved. Now, I would like to ask him to supinate his forearm and show it up to the ceiling and ask him to make a fist. Is he able to make a fist?
Yeah, that is difficult because of just joint stiffness and small joint involvement. So
Now I ask him to make a circle, touch his thumb and index finger first.
that is also difficult.
Difficult. Now I ask him to make a star, touch each of his fingers with his thumb.
He's going very slowly, but
Very slowly.
feeling difficulty.
Okay, Danish. Please do let me know just in case you have pain during any of the procedures, and maybe we could avoid them. So next I proceed and ask him to do a namaste.
Okay, because of the joint swelling, that is not
He's
possible.
not able to do it.
Yeah.
Okay. Oh, what about an inverted prayer sign? Even that is difficult.
Yes, that is also difficult.
Okay. Now I actually ask him to extend his wrist, and I'm just checking at the metacarpophalangeal joints. I'm trying to squeeze a little and looking
that
at
is
his
very
face.
painful, doctor. Don't do
Very
this.
painful. Okay, I'm not doing. Okay, Danish. Okay, sorry. So next I asked Danish to put his arms up towards the ceiling and look up.
Yes, he's doing. There's no problem.
He's doing good. Good to know. And ask him to flex his elbows and put his hands behind the neck.
Sorry.
Ask him to flex his elbows and put his hands behind the neck.
Okay, that is also difficult. That is also difficult because there is swelling, and
Okay. Okay.
yeah, there
Okay.
is.
Now I ask him to touch his chin to the chest
Yeah, no problem.
and turn to his left and right shoulders.
That is little difficult during the movement. That is lateral movement. That is difficult.
Oh, okay. Now I ask him to try and touch his shoulders with his ears on both sides.
Left side is not possible because of joint involvement in cervical area.
Oh, left side, it's not possible. Hello, lateral he's not able to bend his neck.
Yes, 6 minutes
Okay.
up.
6 minutes over.
Yeah.
Okay. Okay.
Now you can present your case.
Okay. I would like to finish my examination by asking him to lie down and checking his lower limbs and the thighs for flexion, extension, internal rotation and external rotation, and also his knees for any effusion, and also check for any tenderness or swelling and the movement of at his knees. Also check the flexion at his toes and see for any tenderness in his toes. So
Okay.
today
So,
I had the chance to examine a 14-year-old boy, Danish, and he seems to be not appropriately grown for his age, though I would like to plot him on the age appropriate growth chart. And also he has eye signs, probably signs of uveitis. I don't know, there is some iris adhesions, probably signs of uveitis. And majorly he has involvement of the wrist and the small joints of his hand. There is fixed flexion deformity at the interphalangeal joints, as well as the wrist shows effusion and tenderness, and there is restriction of movements at these joints. Also, there is some restriction of movements at his neck.
okay. So what is your most likely diagnosis?
My most likely diagnosis would be juvenile idiopathic arthritis. Is a polyarticular arthritis. My most likely diagnosis would be a polyarticular arthritis.
Okay.
Yeah, with systemic involvement.
So, yes.
Yeah,
So,
yeah.
okay. So if what are the DDs? What are the DDs?
So my first I would like to elicit history from the child and know if there are other systemic symptoms, and the most common I would think of first is juvenile idiopathic arthritis. Then seronegative arthritis, maybe.
Okay.
And if the child has any rashes, maybe psoriatic arthritis.
Yes, but the rashes is not there in the skin.
No rashes, yeah.
Okay.
I can also see that the child has some symptoms. Cushingoid facies, is it? Because he's on steroids.
So that is a different case. That is not. That is given in some other region. I will discuss that.
Okay.
So during your examination, if what are the other system you want to examine? If you get time.
I would like to examine. I would like to do a detailed ophthalmic examination.
Detailed ophthalmic examination. What are the expected finding over ophthalmic eye examination? What are you expecting in eye examination?
The child has iritis. So basically, I can see that there are some adhesions. I would like to see how is his field of vision and his visual acuity for that, and also see if there is any adhesion to the lens, and see if there is any cataract.
Okay, cataract. Why you are thinking cataract?
Because adhesion, iris adhesion to the lens can cause sometimes rate.
Okay, I will come to this part later on. Just
Okay. Next, I would like to examine his CVS examination. I would like to do because pericarditis can be associated with this, and also lung examination to see if there is any pleural effusion, and also check for hepatosplenomegaly.
So, what are the types of GIA? What are the criteria for this diagnosis?
You're asking for systemic onset GIA.
No, I asked what are the types of GIA?
Types can be polyarticular, and in polyarticular, it can be either rheumatoid factor positive or negative. It can be oligoarticular and systemic onset.
Okay, enthesitis related. Right? Enthesitis related arthritis. This is another one. Okay. So,
Okay. Okay.
so what are the investigation you want to do for this child?
I would like to do a complete blood count and then
This is a
CBC, CR. Yeah, the
wait,
complete.
wait.
Yeah.
This is a post-graduation level examination. So whenever you are just giving your answer, try to give
With
in
reason.
with
Yeah.
reason. Yeah, you are
Yeah. Yeah.
doing
Okay.
you are doing eye examination. So at the same time, you will tell the expectation. What are you looking for? You are telling the investigation. You will also mention the uh, like result. What are the expected changes maybe in the investigation? That will be more appropriate. Okay.
Okay, okay. So I want to see the complete blood count because there can be anemia and or thrombocytosis can be there. Then I would like to do the inflammatory markers like CRP, ESR, and ferritin. Serum ferritin because I also want to rule out some infections and inflammatory markers will be increased in JIA. And next, I would like to do the rheumatoid factor as well as the anti-nuclear antibody and an echocardiogram to see if there is heart involvement and chest X-ray to see if there is any pleural effusion and an ultrasound abdomen to see if there is to see hepatosplenomegaly.
So what? Okay, how you will manage this child?
I would like to inform my consultant and involve a multidisciplinary team, which will involve the orthopedician and the physiotherapist, ophthalmologist, cardiologist, and pulmonologist, and a psychologist also. With a social worker, I would actually start the child on NSAIDs,
What is that?
like in a non-steroidal anti-inflammatory drugs,
Okay, like
um, like ibuprofen. And systemic steroids can be used, systemic steroids, and sometimes we can use methotrexate.
okay.
And
So,
yeah,
so do you think any kind of rheumatological opinion is important?
yes, yes, yeah. Rheumatological important is very yeah, is very important. Yeah.
So you are using methotrexate, right? Suppose. Then what are the side effects you will be aware of?
It can cause folic acid deficiency, so folic acid should be supplemented.
What are the other complications using this medicine? I mean side effects.
Mhm. Mhm. No idea, Dr. Pranab.
Okay, we'll discuss that. Okay, what are the other modalities of treatment?
Yeah, I would like to then other measures like maybe massaging and icing the lesions where there is swelling and slowly start some physiotherapy exercises. Also involve the occupational therapist to improve the daily activities of the child. And I would also like to liaise with the school about the child's condition and have an education plan for him.
Okay.
Yeah.
So Do you think that systemic steroid have any role in this child?
Yeah, sometimes they can be used when the pain or the swelling is not subsiding with non-steroidal anti-inflammatory drugs, then maybe next stage we can use steroids.
Suppose why I have kept this picture here. This child, suppose this child, Danish, having gradual over time having this change of facial feature after
Okay.
using steroid. After using steroid
Steroids. Okay.
with the long term. So, what may be the complications of steroid?
Steroids we can start with obesity and moon-like faces. It can cause easy bruisability and hypertension, and sometimes it can cause raised intracranial pressure, and they can cause striae over the abdomen.
So together all these
And
features,
also the
what is
bone abnormalities.
definitely together all this finding that is
Yeah,
mostly
Cushing syndrome. Yeah.
that is one of the most common complication of chronic steroid use, right?
Yes.
So
Yeah.
why selecting this picture? Because some of the children not will be there with this classical finding. Some children will have just well controlled of the joint pain and swelling, but the child may be obese, with some pain examination may be there. So if any just this neuro, I mean the MSK station, if we find that the child having some obesity with some pushy white feature, and the task is do the PGAS, then we need to think that some chronic steroid use may be there for this obesity. Okay, iatrogenic Cushing syndrome is most common, na? So Cushing syndrome again one of the common exam case. So we need to be very careful. And during your examination, if you forget to mention the eye finding, I mean during the examination of the face, this for 4DMS, at the same time you need to see the eyes very closely, and after that during your presentation you missed this wasted part, and
Wasting part. Yeah.
this is wasted in the chronic
Yeah.
there was some wasting. Okay, so these are the clinical findings. According to that we'll just observe. Okay.
Dr. Pranab, I just have one doubt. Usually in JIA, there is no uveitis, na? That is why I was a little confused. Yeah.
Okay, GIA, that GIA, not all the cases, they are may or may not be. May or may not be. If the ANA is positive, okay, there is high chance the child will having uveitis. So why I have selected this picture? This is basically due to what? We should not forget in the exam to mention the eye finding. That's why. Okay.
Yeah. Okay.
There may be in polyarticular GIA, there may or may not be. Just only in a positive 25% cases. So may not be just this finding eye finding is there. But what we need to remember that uveitis is rare, but can be present polyarticular as well. But if we miss this finding, that will be very they will be just deducting the marks. Okay.
Done.
So in this way, we'll just proceed for the this GIA discussion and case. After
Dr.
that,
Pranab, then at what point of the examination maybe we can look at the eyes? Because after the gait, we are straight away looking at the hands, right? Arms.
okay. So if the task is PLs, then sometimes it's possible that there may be some other finding because there was neck involvement. No? So polyarticular GIA with cervical spine involvement. Okay. So that's why PGAS was important, because if we find any kind of abnormality in the hands only, that's fine. Okay, that's fine. And at the same time, if you miss any finding over the neck, that is cervical area, they will be deducted marks. So that's why they have given the opening statement. Just examine the child, that do the PGALs. And as a part of PGAL, you can start with the gait always. That will take hardly few minutes only. I mean, few seconds.
Okay. Maybe at the end, can we look at the eyes after checking the legs also?
Definitely. Even if you miss, then you can present your case with this eye finding. Sir, I will also look for eye size or eye examination in detail, because there may be some eye involvement. Okay.
Okay.
And this is basically PGAL. That's no. Now this is our next case. Other people who are already confirmed their seats. Okay, so in this case, 13-year Bethany girl do the PGALs or the opening statement now is do the lower limb examination of the PGALs. We have a just a minute.
Hello.
Examination. Yes.
Hello.
Yeah.
Is anybody doing it who has got exam, or I can do it?
Yes.
Okay.
You can do it.
Yeah, just give me a minute.
Sure.
Dr. Pranab, about the side effects of methotrexate.
Okay, so side effect basically neutropenia. Sometimes leukopenia will be there. So what will be the child may have some chances that the child will get some bugs. I mean the infection very easily, especially throat infection. Okay, so we need to check the blood count on a regular basis. Okay.
And what about the question you asked about use of steroids? Like
use of steroid, chronic use of steroid may cause cataract as well.
okay.
You are saying looking for cataract.
No, you asked if it can be used, right? It can be used, no?
Yeah, definitely. Prednisone has role.
Okay.
Okay, so chronic use that the child may have cataract as well in the eye finding.
Okay.
Believe me, guys, if you just take your time and just pausing the recording. Just a minute. Your time starts now.
Okay, so I'm entering the room, washing my hands. Hello, Bethany. I'm Nisha, one of the pediatric doctor here. How are you today?
Yeah, I'm fine, doctor.
Okay, good to see you. Thank you for coming here, Bethany. So, are you okay, or are you in any pain anywhere?
So, okay. So I have a little pain in my left-sided knee.
Okay. So before we start, let me ask you a few questions. Do you have pain usually when you walk upstairs or downstairs?
Yes, there is some pain.
And when you write or button and unbutton your dress, do you have pain?
Yes, there is no pain.
No, okay. When you're using fork and spoon during eating, no pain?
No.
Okay, okay. Fine. Are you able to stand for me?
Yeah, she is standing.
Okay, okay, fine. So, right. So sorry, before that, I will see there is no Bethany doesn't look in any distress from the picture I can see. There is no dysmorphic features. I would like to ideally plot her height and weight on the growth chart. And if I would like to see if she has got any devices attached and she's got anything in the surrounding like orthotics or special shoes or anything, walking aids.
No,
Okay. Okay, she's 5-year old. Okay. So during standing, how is she standing?
she is standing in a flex posture at the knee joint.
Okay. Would you be able to walk, Bethany?
Yeah, there is a leaping gait, but difficult to walk.
Okay, okay, fine. Okay. Would you do you usually okay, I would like to I don't know. I would like to skip Gower sign in this case, as this is
Yes, no need.
quite painful.
No.
Okay. Would you be able to? Okay, I'll observe Bethany from front side and the back. If she has got any scars, pigmentation, any obvious deformity, or any obvious swelling anywhere, I would have a look. Also, spine. I would have a look at the spine. If there is any kyphosis, scoliosis.
There is no kyphosis, no scoliosis.
Okay, okay, fine. So, so in the lower leg, I can see the knee joint, the left knee joint, quite swollen, red. Uh, yeah, and the right side is normal. So I would like to. There is no any scars or sinuses or bruises over it.
No.
Yes. So I would like to, Bethany, I'm gonna touch it gently. Okay. If at any point, if it hurts, please let me know. I will stop it. Okay. So I'll gently touch I will examine the right knee joint first to see if there is any pain, tenderness, or anything. And then compare it with the left side to see temperature, tenderness on superficial palpation.
Okay, so there is raised temperature, a little raised temperature, as well as swelling is there. And what else you would see?
So temperature, tenderness, and so on superficial palpation, I'll just look that, and the extent of the swelling. I'll also measure the swelling. I'll ask Bethany to do the passive movements if she can flex the knee joint.
Okay,
First
so
right and then left.
yes. So right side there is no problem, but left side there is restriction of the movement. The flexion is some degree flexion is possible, but extension is restricted.
Okay, okay. So I will gently do it with myself, and I'll watch at her face if there is any pain. If there is any pain, I'll stop. Okay. So I'll do the active flexion. How is the pain? How is the flexion? Is she allowing me to do flexion extension?
So first active, then passive. Okay. So the child is trying to flex, but flexion is restricted as well as extension also restricted in the left side, but right side there is no restriction.
Okay, okay, fine. So I will like to do the patellar tapping and do the like to check the knee fusion by
Okay,
pressing the patella downwards gently. I will try to be gentle as possible see if there is any fusion.
so no effusion. I mean, sorry, there is severe. I mean, not severe, but little bit of pain. Just you need to do very carefully.
Okay, okay, okay.
There is
Yeah.
no effusion. You can do the patellar tap, but
Okay. Okay, fine. So I would like to check the upper joint, the hip joint, and the lower joint, the ankle joint, by doing all the joint positions. So in hip, I will check the flexion, extension, adduction, abduction, internal rotation, external rotation. And in the ankle, I will check dorsiflexion, plantar flexion, inversion, eversion, and circumduction. If huh?
So ankle joint is not involved, only the knee joint involved, and hip joint there is no findings. Okay.
Okay, fine. So yeah, now that's it. That's it. I'm finished with her lower limb examination. But ideally, I would like to do whole all check all the joints, including spine, and do other systemic examination to complete my examination.
Okay.
Thank you,
Minutes,
Bethany.
6 minutes and 50 seconds. I forward to see the time.
Yeah,
You got 1 minute extra. Okay, so present you please.
So I've seen a 5-year-old girl, Bethany, today, who came in with left knee pain. Her on examination, her rest of lower limb examination are normal, except her left knee joint, which appears to be red, swollen, and tender. Um, uh, on examination. Also, there is restricted active and passive movement in all directions. It is warm to touch. Also, she denies having the chronic symptoms and other on the screening questions. She denies in there is negative screening questions in which can indicate other joint involvements. So my possible most probable diagnosis is septic arthritis, but I would like to rule out if it is onset of oligoarticular GIA or
Okay, fine.
Yeah.
So I will stop you here. So why you are thinking this is septic arthritis, not GIA?
Because it's warm to touch, it's tender, and it looks red inflamed.
Okay.
And
so if you see oligoarticular juvenile idiopathic arthritis, there may be some degree of inflammation as well. Definitely, depending upon the severity, you can put your DD as septic arthritis. That is right. Your thinking is very good. Okay, but my point is, the most of the children will be no pain, but some degree of pain may be possible with redness. That is also kind of information. Okay, so first one patient, what in just like acute condition, they will not be giving the septic arthritis. Septic arthritis is a very acute condition, right? So this is very unlikely they will be giving in the exam.
Yes.
But one of the most common and very close differentials, as you just said, that is septic arthritis, definitely. But this is most likely the
oligoarticular. Yeah,
okay.
is it their temperature as well? Like,
yeah, there was slight temperature and redness also there, which is swelling, definitely.
Okay.
So first DD is oligoarticular, but if there's severe pain, the child is crying, and this, so you have examined the child and you have done the pedular tap also. Do you think that is septic arthritis that will be possible that you will do the pedular tap?
No.
So, and you miss the crepitations. So during your pedular tap, you also feel the crepitations during the joint movement. That is very important. Right? So feel the crepitations, and after that you need to do in knee joint flexion extension 2 movements. In the hip joint there is 6 movement, and in the ankle joint there is also 6 movement. So if we miss any of the moment, definitely in the exam they will be deducting marks. And always we need to compare bilaterally. First normal one. Okay, the 6 movements. Like bilaterally, well, first suppose we are doing the hip. So first, okay, let's start with the knee. The knee is affected. So first in this knee, so there will be normal flexion extension, and compare with this one. So flexion extension is like restricted with this joint movement, joint swelling. And after that we'll do peroneal tap as well. Okay, and after that in the six movement in the hip joint. Okay, that is flexion extension and adduction, abduction, internal and external rotation over. Then in the ankle again 6. So 6 movement is a compulsory, mandatory, must. Otherwise examination is incomplete. They will write just like incomplete or in not appropriate. I mean the structure, not structured approach. Okay, so I think you have done these steps, but you missed most vital part here. Can anybody suggest what is the important finding she missed? Can anyone suggest here one of the very
Cushingoid face is
Cushingoid face is okay. That may a little bit of Cushingoid as well. Okay. That apart from this, any other thing? Any other thing? No. Okay. So that is important in MSK. That is called LLD. If you miss LLD, then definitely they will be giving you half marks.
Oh yeah, okay.
So here, as you can see, this joint is involved restricted movement. If this is a chronic condition, definitely limb length will be affected. So at the end, you need to measure the limb length.
Okay, okay.
So there is no such gross wasting, but some degree of wasting may be there here and maybe there in the calf muscle as well because of the joining moment. Okay.
Yeah.
So we need to assess all this finding.
If you mention it is sufficient, na?
Yeah, definitely. You need to comment. If there is no time, definitely every one of us need to comment on this. Otherwise, they will be deducting the marks. 100%. Okay. Okay. Now the list of discussion. The most common differentials is septic arthritis, right?
Arthritis, trauma.
Trauma, you need to definitely give us DD first, then septic arthritis, and any other DDs which is important.
Malignancy.
Malignancy, excellent. So malignancy. If you are suspecting, how clinically you will differentiate all this condition.
So I would like to take the history and do the rest of clinical examination. And I would like to do the investigations.
Okay, no, clinically, not investigation. Clinically, how will they differentiate one by one? So history will be prominent. History will be.
Okay. Yeah, history will be telling us.
Calling history. The trauma is out.
Yeah, so if there is history of trauma or bruises, one of the DD could be hemophilia as well, and there will be bruises as well.
Are you expecting a female child with this presentation?
No, sorry. Yeah, sorry.
Okay. But that is definitely a DD. You can put and you can say that hemophilia is one of the cause of this kind of joint swelling, but this is a female child, very unlikely.
Yes,
okay. Next.
So septic arthritis would be very, very painful.
Yes.
And
what are the other clinical features you will get in septic arthritis?
It's hot and very tender to touch.
Yes, definitely. Redness, hotness.
Yeah.
difficult to examine. Your child will be very much painful.
Yeah.
Yes.
Sorry, Dr. Pranab. Sorry to interrupt.
Mhm.
In this picture, this particular case with that leg and Cushingoid faces, what will be our first?
Okay, so if this is Cushingoid face, okay, so oligoarticular arthritis, I really don't know they are using steroid or not. Okay, methotrexate is most commonly used with inflexible. If they are using steroid, that is possible, also possible, a systemic steroid. Okay, otherwise very unlikely that they will have this kind of Cushingoid faces. This is because
Here you have for Cushingoid only.
yeah.
The
The
face
face is rounded. Yes, you're right.
What will be our DD with Cushingoid face and monoarthritis?
Yes, right. But if because we need to keep an eye over everything, not only the face. That's why different clinical feature. I don't know with this picture with varieties of cases and with varieties of pictures, so that in examination, if any kind of similar finding is there, we should identify it. Because most common cause of Cushing syndrome or Cushing syndrome is arthritis. Most common, right? So that's why if the child is in a steroid, definitely we need to think that this Cushing syndrome or Cushing faces may be due to steroid only. Okay, but here I don't know why I have selected this picture, but anyway, so that is also possible. If the child is taking steroid, then this Cushing faces is also possible. Now we are discussing the causes, that is in septic arthritis, how you will clinically differentiate.
Dr. Pranab, sorry to interrupt, but I have one basic doubt. When the child is in pain, can we really examine the joint? Because even in my case, I really had a doubt, but since it was P-gals, I went to the arms. But can we examine the joint when it is involved?
Okay, if the joint is severe, painful, that is, I say there is little pain, not so pain. Because if this is septic arthritis, definitely you are not going to examine the child. Septic arthritis is very unlikely in our clinical station. Very, very unlikely. Yes, there is swelling and there is some degree of pain. That's why that is possible to do few examination of this joint swelling. Few also. Okay, that's the reason.
Okay.
Or that is totally depends upon the pain. If the pain is severe enough, the child is complaining of pain, do not make her cry. Otherwise, they will give big zero. That is the drawback basically of this examination. So better to avoid the detailed examination if this is severe painful. Okay.
Yeah.
The pain was minimum, that's why she allowed to examine her. Okay, now the septic arthritis. How will you differentiate clinically septic arthritis? There will be pain, swelling, joint, and there is rise temperature, redness. Okay.
Yeah.
And
tenderness.
Tenderness. All this feature will be there, along with some systemic. Fever may be there. If this is history of fever, may be there.
Tachycardia.
So all this tachycardia also, the patient will be very much sick.
Septic, yeah. Maybe.
Okay, so these are all the features.
Mm-hmm.
Now, the next question is, if you are suspecting, that is one of the DD, that is malignancy, then what are the clinical feature you will look for in this child?
So basically history again, and then hepatosplenomegaly lymphadenopathy.
Hepatosplenomegaly lymphadenopathy, very good. And
in the
sometimes petechial here, low platelet may the bruising, bleeding tendency may be there.
Yeah, petechial.
So all this feature will be there. Right? Now, what are the investigation you want to do for this child?
So first, I would like to do the blood test, including full blood count, renal function test, the CRP, ESR.
Expected finding. Please tell
So
the
yeah,
expected.
in full blood count, I would look for HB neutrophils and white cell counts, platelets, to rule out my differential, like septic arthritis. There will be neutrophilia and raised white cell count. In leukocytes, it might show raised neutrophils, white cell counts, and low platelets, low HB. Also, if it's septic arthritis, the CRP will be very high. I would like to order the request blood team to see any blood cells to rule out the malignancy. And for rheumatic, for oligoarthritis GIA, I would like to investigate, request ESR to see raised ESR as it's chronic condition. The rheumatoid factor, it will be negative. If it's if it's GIA, and ANA as well.
Okay.
ANA. Also, I would like to order X-ray of the
Yeah.
joint to see if there is any destruction of the joint, or any fluid, or any trauma if I missed it. Also ultrasound and CT MRI if needed, to rule out septic arthritis if there is any acute history.
Okay.
Also biopsy if there is effusion. Sorry, not biopsy, the centesis, fluid centesis.
Okay, that is for needed for your
Hemarthrosis,
septic arthritis.
septic and hemarthrosis, yeah. Also, yeah.
Okay. So
yeah.
if how you will manage this child?
So I would involve my consultant and also the rheumatologist, orthopedics, and physiotherapist, occupational therapist, and orthotics. If it's like the chronic condition like GIA, if it's so I would like to give the NSAIDs, the ibuprofen, and naproxen mainly initially, as a first choice. Then if it's not better, then second line treatment at local steroid injections and methotrexate, depending on the rheumatologist, tertiary centers.
Yes. So you need to involve the rheumatologist, and first of all, you need to involve in every station, you need to involve the consultant first. After that, the multidisciplinary team, including the rheumatologist, and lastly, the psychological opinion, because the child may have some psychiatric problem.
Yeah.
So that's why. Okay.
Yeah, I will, during treatment, I would monitor the side effects of the medicines.
Exactly.
Yeah.
Okay.
And yeah. Okay.
So what are the other system you want to examine apart from this joint?
So I would like to do head-to-toe examination, including eyes examination, as this can have uveitis or iridocyclitis. Or it can have cataracts as a side effect of corticosteroids. Also, the chest examination and cardiac examination, as it can affect the heart to
Not all the cases. Not all the cases.
Yeah.
Is very unlikely, but you can mention it. It's better to just avoid. And
Yeah.
eye examination is must. If you forget eye examination, then definitely in oligoarticular GIA, definitely there will be some problem. Right?
Yeah. Yeah. Also, abdominal examination for hepatosplenomegaly.
Yes.
Yeah. And I would like to do the blood pressure to see if there is any hypertension, and blood sugar to monitor blood glucose if the child is on steroids.
Yes. So the child is not in steroid, so that's why there will be no defining.
Yeah.
But, okay. So this was our second Okay, so any other feedback, guys, you want to mention here?
If it is oligoarticular GIF, first management you have to say about, apart from the consultant or anything, that's interarticular steroid. That is the first choice. Then you can say other things. And if it is the polyarticular GIF, then you should say the Mrcpch is the first line, and the NSAIDs like ibuprofen.
Actually, what I feel, Abhishek, that will be decided by the rheumatologist. That's why rheumatological opinion is very much important.
Yes, we have to say the rheumatologist, but after that,
Yeah, definitely.
the first choice will be interarticular steroid for oligoarticular GIF.
Yes. Right. Triamcinolone is the choice. Okay. Any other feedback?
And what are the systems you say? Dr. Pranab, only eye and what?
No. Eye examination. Rest of the examination he mentioned. She mentioned. I think that is systemic examination, including the hepatosplenomegaly.
All the things I have to say about the.
All?
Okay, everything I have to say. I have to say everything like cardiovascular,
No.
abdomen,
Cardiovascular really involved, but if you want, you can say at
blood glucose.
So that is dependent on if the child is on steroid, some complications will be there. At that time, you can check thoroughly in every system. If the child is do not have any kind of complications, then eye is must. So never ever forget to mention the eye. Eye is must, and again limb length discrepancy. Okay, that is also important. So orthopedic surgeon opinion is sometimes important.
Dr. Pranav, hello, can you hear me?
Yes.
To avoid the haphazard examination, if I do the right leg, hip, knee, and ankle, everything first, and then left leg, instead of doing everything.
No, never.
No, so side by side way.
Side, always bilateral, always bilateral. You need to compare, including inspection, palpation, and like movements. Everything will be bilaterally. Otherwise, they will be deducting marks. Unstructured approach.
Clinically, when we do this, no? When we actually do clinical examination on patients, the normal leg first, and then we do
No, it's always bilateral. Bilaterally, that will give some clue about the restriction or pain, anything. So that will be helpful. Bilateral. Even in Mrcpch, they have written bilateral, always bilateral. Compare with bilateral.
It of more time. No?
But there is no other option, no other choice. The approach is always bilateral. Okay. Any other feedback, guys? Otherwise, we move for the next. No. Moving.
Thank you.
Thank you. So here, this is just a picture, as you can see. Can anybody suggest? This is for just just not for practice, basically. So this is just for identification of the clinical signs. Number one, here is the joint swelling. Here is also joint swelling. And as you can see, here is also joint swelling. So what are the clinical signs you can see over this picture? If
There
this
are
is
bruises as well. There are bruises as well.
number 1, number 2, and number 3.
In the number 1, there are bruises, and it's quite big swelling. Looks like hemarthritis.
Right. So here, first thing, some venous prominence is also there. Right? Here in this picture, and this is most likely hemorrhasis. And here, as you can see, this is most likely septic arthritis in this picture. Redness is there. redness is there, as well as some redness,
Abrasion mark.
swelling, abrasion mark. So all this together with some features of cellulitis, this is most likely this is septic arthritis. And here again in this picture, last number 3.
This looks like oligoarticular here.
This look like oligoarticular, but the age is I don't know the age, but this is, yes, oligoarticular, or maybe, but the knee joint is involved. That is GIA mostly. Not so much of inflamed, but the swelling is there, right? Okay, so this was the differentials of joint swelling in the lower limb. Okay. Now these are the DD, as we discussed, that is soft tissue. First thing, trauma, cellulitis, and soft tissue injury. Second thing, osteomyelitis, septic arthritis. Hemophilia is one of the DD. Malignancy, reactive arthritis, systemic rheumatoid, systemic, there will be hemophilia as well as fever. Non-accidental injury, one of the DD as well. Okay. So I'm not going into the detail, but here. Okay.
Sorry for the last picture. What do you say? Sorry.
Which one?
Sorry, internet. Sorry. Last
Which one?
picture number 3.
GIA.
What is the
GIA.
number 3?
Yes, GIA.
Okay. Oligoarticular GIA. Okay.
Most likely oligoarticular. Most likely.
Okay. Thank you, man. Sorry.
Don't be sorry. It's okay.
Thank you.
So here I'm just removing this picture. Actually, this is a mixed kind of picture that is not exactly. This rashes will not be there. Okay. We'll forget out this. I will just move for this case. 13-year column, kindly examine him or do the figures. Okay. So your time starts now.
Good evening, Callum. I wash my hands. How are you, Callum?
Doctor, I have very pain, so in the neck as well. So I'm feeling very much of depressed.
Sorry about that, Callum. That is why I'm here to examine you. Is it okay? Can I go ahead and examine?
Yes, sure.
Thank you. I find Callum is not distressed. He's very he's in pain. That is obvious. He does not have any dysmorphic features. He's not on any devices. Nutritionally, his dimensions look good, and he is quite alert. So now, Callum, tell me. I need to ask you a few questions. Is that okay?
Yes.
You have said you have pain in the neck. Is there anywhere else pain?
So in the neck as of now.
Okay. Do you have any stiffness in the neck or any other joint?
The neck as well as in my lower limb, basically at knee joint in the right side.
Okay, there is stiffness. Are you able to climb up and down the stairs?
Yeah, there is some difficulty, some degree of difficulty.
Okay. Are you able to dress and undress yourself every day?
Yeah, there is no problem with the dressing and undressing, but just whenever I am just combing my hair, at that time I find sometimes difficult.
You find pain in the
Neck,
joint,
neck,
in the
neck.
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 Okay. 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 Is there any, are you using any aids to walk?
No, as of now, no, but yes, pain is there.
Okay, okay. So I want to examine him from the anterior aspect. Am I noting any obvious deformity or any asymmetry on the
Which part?
anterior aspect?
Okay, no. Anteriorly, you need to expose the child. Basically, he is
Yes,
wearing
yes,
the
yes.
shirt to expose the child. There is no abnormality in the anterior view.
Is there any muscle atrophy, any
No.
particular posture, any
No.
skin rash, any scar anteriorly?
Yes, a rash is there just at the level of elbow, as you can see in the picture.
Mhm. Okay, it's the rash is only on the hand, nowhere else.
Only in the hand. No.
Okay, and how does the rash appear? Is it
This is
how is it looking? I can see it is
the
reddish. It has
scaly.
well-formed margins and scaly. Okay. And then on the lateral side, am I seeing any obvious spine deformity or any contractures on the lateral view?
No.
So then going to the back, am I seeing anything, any rashes or any scar marks, any scoliosis in the
Nothing.
back?
Nothing.
Okay. So now, Kalam, are you able to walk? How is his normal? How is his gait? Is he able to walk?
Yeah, gait is anterior gait, and there is some degree, some very little degree of flexion deformity, and he is working with the tiptoe on the
He has flexion deformity where?
knee joint. It's
Both the
very
sides?
no, it's I said it's left or right. I said it's left. I think no? Left. Yeah,
Left
left.
joints, okay, flexed. And he's tiptoeing on that side or both the sides?
Only that side only.
Okay, okay, antalgic gait. Okay, if now, Kalam, are you able to touch the ground? Please bend and touch the ground. Are you able to do that?
Yeah, he's able to do that.
Okay. Can I feel for his spine? Is there any tenderness?
Okay, so
Any-
span no, not in this. Okay.
Okay.
Only the cervical
Then,
area.
yeah.
Only the cervical area there is little tenderness, very little.
Okay, sorry. So Callum, can you please sit on the couch? And then now I'm looking at, I have examined his rash already. So now you do these movements, please. Is he able to raise his arms, palms up, flexion of the shoulder extension, um, uh, joints movements at the, is he able to raise his arms and palms up, supination, pronation, is he able to do that?
Yeah, there is no problem in supination pronation.
If I try squeezing at his metacarpophalangeal joint, is there any pain?
No pain.
Okay. And then is he able to make a fist sign and star sign?
Okay, and there is no problem. He can make that.
Okay. Okay. Is he able to make a prayer sign or anti-prayer position?
Yes, he's also doing that.
Okay. And there is no pain there.
No pain.
If I ask him to raise his hands above the head and look at the ceiling, is he able to do that? Is there any pain in the neck?
Yeah, there is difficulty extending the neck.
Is he able to touch the shoulders, shoulder to the head on the sides? Is there any pain?
Yes, there is pain.
Okay. And maybe if I ask him to open his mouth and try putting the fingers in the mouth, is he able to do, or is there any pain in the jaw?
Yeah, there is slight pain and difficulty in opening the mouth as well.
Okay, okay. So just lie down, Kalam. Let me check your legs. Is he able to flex, extend, adduct, abduct, internal, external rotation of the hip on bilateral side, right and left simultaneously, one after the other?
Yeah, hip joint, there is no problem.
Knee joint, is there any problem? Flexion, extension on the right?
In the left side, there is little problem during the full extension. And in the flexion, there is, at the end of flexion, there is also problem.
So there is
Pain, basically.
pain. Okay, pain as well as restricted movements. Okay, ankle bilateral. Sorry.
Ankle, there is 6 movement in the ankle joint. There is no. Okay, ankle not needed in figures. Okay, that is
Okay.
excluded. If your
Okay.
opening statement is to the figure, that is not necessary to do the ankle.
Okay.
So yes, 6 minutes is over.
Okay. To complete my examination, I would have wanted to check, do the local examination of the left knee joint. Mainly, I wanted to look first if there are any signs of inflammation, any redness, and also the extent of the size of the swelling. I would also want to measure the limb length, both the sides. I would
Yes.
also want to feel now for the patella tap. Is there any to see if there was any effusion and any tenderness? Apart from that, I could have also measured the size of the swelling, and I would have now looked for restriction of movements, both on active and passive movements.
Okay. So what are the clinical findings you have got in this child?
So clinical findings on general physical examination, I have seen that he is obviously having pain in the neck joint. That is very obvious. But general physical examination, skin, I can see there is a rash which is erythematous, well-formed borders with some plaques. Scaly plaques are present. I have also looked at his nails. He has pitting on the nails that is present. Other than that, there are no other rashes or any scar marks on the body. There's no obvious deformity apart from the left lower leg at the knee joint, I can see. And upon his gait, he has an antalgic gait with toe walking on that side. Spine appears to be normal other than the cervical spine. He has he has some restriction of the movement and pain at the cervical spine. Arms, there is no issue that I could detect. But I have noted that there is pain and restriction at the cervical spine.
So there is a sentence which is like that. The responsibility of the luggage is, who will be responsible if anything happens to the luggage during the travel?
Me, whoever is traveling.
Exactly. So that is in our hand. Okay. So if we are taking so much of time to describe the clinical finding, definitely within 3 minutes, that is impossible to complete or to come to a part of management.
Okay.
So just environment to
I'll
qualify.
summarize. Yes.
Otherwise, if we do not reach up to the part of management, that is incomplete.
Okay.
They will be deducting marks. So positive finding here, 1, 2, 3, 4. There is cervical joint involvement, the restriction of the movement in the cervical joint. There is also some pitting of the nails and some rashes, which is suggesting of psoriatic arthritis. And there is knee joint. Knee joint. In the knee joint, there is some degree of restriction of movement, and that's all. And most likely my differential diagnosis, my most likely diagnosis psoriatic arthritis, and differential with the other group of that arthritis. And let the examiner to give, ask you questions. So presentation is definitely important. That is a cake, basically cake. They said that is a cake. So if you are making the cake,
can I just give it a quick try, Dr. Pranab?
sure.
Can I just quickly? So to summarize my case, upon my PGALS examination, I have noted that this child has pain and restriction of movement of the cervical joint, as well as involvement of the left knee joint with the restriction and swelling of the joint, together with the main features of skin rash, which is typical of a scaly silvery rash and with nail pitting. I would want to consider psoriatic arthritis as my first possibility.
Okay. For the diagnostic criteria, Vancouver criteria, what are the other criteria? Do you know that?
Other criteria, I only know Vancouver criteria.
Yeah, so, just describe the Vancouver criteria.
So Vancouver criteria, either there is a definitive criteria or probable diagnosis. In the definitive, if just one arthritis and the skin rash, typical psoriatic skin rash is there, then that is enough. If you don't have a typical psoriatic rash, then you need arthritis with three 3 of the 4 criteria. In that, I think there's lymphadenopathy. Then there is a psoriatic-like rash. Then there are 2 more organomegaly. So the
Dactylitis and
Arthritis plus 2 out of 3.
I think it's 3 out of 4.
No, three of the four. 3 of the 4. Not
3 of the 4. Dactylitis.
Dactylitis is one of the criteria. Nail pitting or onycholysis may be there. And psoriatic.
Family history.
Family history first or second degree, okay?
Mm.
And probable if there is 2 of the 4 minor criteria. Arthritis with 2 of the probable, that is probable, okay?
If 2 are there, then that's probable.
So what are the investigations you want to do for this child?
So first of all, we would want to look at the psoriatic arthritis side. So for the diagnosis, we would want to look at the inflammatory markers, the CRP and the WBC count. Also, we would want to look at the X-ray of the joint to see the degree of destruction and the involvement. Apart from that, we would also want to take the skin to diagnose psoriasis skin problem. Probably you can take the scraping from the.
Okay, so that will be easier if you just suggest the DDs. What are the DDs is possible? Then the investigation will be more easier.
Yeah, because it fits into the Vancouver criteria. This my first possibility will be psoriatic arthritis. Second possibility, because it is monoarticular, it can be trauma related, or it can be reactive arthritis.
Why monoarticular? Why you say monoarticular?
Oh, sorry. There is a. It's not monoarticular. Together with the cervical spine involvement is also there. So
rash with this arthritis.
Yes, rash with arthritis. It could be systemic onset juvenile idiopathic arthritis.
That will be, there will be fever.
There will be fever.
Is there any possibility of juvenile dermatomyositis?
Possible.
Rash with arthritis or like joint pain or difficulty in walking, muscle weakness, proximal muscle weakness. Okay, so that's why I say always go GAWA sign, because if this is dermatomyositis, so that is those very rare. But if we do not do GAWA sign, that is possible that we may miss, right?
Yeah. Correct.
Okay, so now what are the investigations? What are the investigations you want to do?
It is it's still the inflammatory markers together with ANA and rheumatoid factor. Yeah.
The rest of the thing you mentioned, okay, that is given in the mark with you, okay.
And all,
yeah. Okay, so just like this inflammatory marker, as you said, mentioned, that is ESR and CPK to rule out other conditions basically. Okay. So LDH.
For psoriatic skin, Dr. Pranab, they take the swabs. How do they diagnose? Is it the skin scrapings that they use for diagnosis?
Psoriatic arthritis, just I need to see basically this part. That is mostly clinical, but the inflammatory marker will be raised. Definitely. Inflammatory marker will be definitely raised. Okay. Now, basically this is the management is basically same. Okay, diagnosis confirmed by the biopsy. They said biopsy is needed. Biopsy is from where they will take the biopsy. Biopsy is confirmatory. And as a treatment management part, how will you manage this child?
It is similarly, you can use pain management and anti-inflammatory management. So pain will be in NSAIDs like ibuprofen or piroxicam relief, those drugs. For pain management, if it is oligo articular, of course, I will involve all the multidisciplinary team. So there can be a pediatrician, there needs to be a physiotherapist, occupational therapist, rheumatologist to be there. So for the management, apart from the NSAIDs, you can use intra-articular steroids, mainly triamcinolone can help. If not, and if it is really florid, and if these drugs are not helping, then you can use disease-modifying drugs like methotrexate.
Yeah. I'm sorry, biopsy. I was reading from other books actually. The biopsy is not needed here. That is for dermatomyositis actually.
Okay.
So inflammatory marker will be raised, and rest of the finding is clinical. Okay. So in that way, we just diagnose it. The definite diagnosis, there is no specific test, I think. Okay. So this is how the similar. Binding is mostly the similar of the GI. Very, very similar. Okay. The drugs they are using, just like in NSAIDs, just like naproxen or maybe then steroids, and then intraarticular triamcinolone, as you said. Oral steroids sometimes possible, and methyl prednisone sometimes, and immunosuppressive drugs, just like methotrexate, cyclosporine, sulfasalazine, that is infliximab, and side effect sometimes can be asked. So we need to know. Okay. And new modality, sometimes new modalities of treatments they can ask. That is interleukin 1 and 6 inhibitor.
Interleukin 6.
You need to know that.
Human necrosis factor inhibitor.
Huh?
Human necrosis factor inhibitor, like
Yes.
infliximab.
Yes, right. Okay. So we'll take a break and we'll start again. It's around 9. Okay.
Thank you.
Thank you.
Thank you.
Thank you.